Good afternoon, and thank you for joining us here in the Washington, D.C. office of Mathematica Policy Research, and also to everyone attending by webinar. I'm Gene Rich, and I'm the Director of Mathematica's Center on Healthcare Effectiveness. It's my pleasure to welcome you to today's forum on the Medicare Sustainable Growth Rate Formula and physician payment reform. Before we get to the substance, a few housekeeping items. Our session today includes both an in-person and online audience by webinar. To help ensure the highest quality sound for our webinar participants, we ask those of you here today to silence your electronic devices, which I'm remembering to do right now. Please note we are video recording today's session here in the DC office. That'll be posted on our website next week. At the conclusion of our presentations, we'll entertain questions from both our in-house and our webinar audiences. For those of you participating by webinar, you can submit your questions electronically at any time through the Q&A panel, and we'll alternate your questions with those of our in-house audience. Now I'd like to say a word about the Center on Healthcare Effectiveness. CHCE conducts and disseminates research and policy analyses that support better decisions at the point of care. Our focus is on the delivery systems and policy environments that help clinicians and patients make more informed decisions using information on outcomes and effectiveness. Our research addresses that complex environment within which clinicians and patients make healthcare decisions. Today's meeting highlights an excellent example of that kind of work, investigating the market, delivery system, practice setting, and point-of-care impacts of changes in the regulation and payment of Medicare providers. For more information about the work our researchers are doing or about upcoming CHCE publications and events, I encourage you to visit our website. Now on to the reason we're here. As everybody knows, Congress is again attempting to repeal the Sustainable Growth Rate Formula. The SGR is a mechanism to control Part B spending under the Medicare fee schedule. It sets an annual per-beneficiary spending target based on GDP growth and annually adjusts physician fees up or down. Its history is complex. It operated as intended from 1998 to 2002, and in that year the SGR mandate mandated a 4.8% cut in physician fees. After that year, Congress has overridden other mandated fee cuts in all the subsequent years. These fee cuts, however, have accumulated so that by April of 2015, if Congress doesn't take action, the SGR formula would mandate a cut of Medicare physician fees by about 21%. Now, such large fee cuts are obviously politically untenable, and this annual SGR override process has been a source of political struggle, angst on the part of the Medicare provider community, and a certain degree of inefficiency on the part of both Congress as they grapple with this problem year after year, and the administration as they gear up under law to implement these drastic fee cuts. Now, the Medicare Payment Advisory Commission and other advisors have observed that the SGR is not really effective payment policy anyway. They note that it targets prices but places no control over the volume and intensity of services. It alters fee updates, therefore it equally affects efficient and inefficient Medicare providers, more effective and less effective services, and it equally affects services that are overvalued and services that are undervalued in the Medicare fee schedule. So consider, for example, primary care services, which MedPAC and others considers to be undervalued. Under the SGR, come April of 2015, a geriatrics primary care physician would see each of their primary care service payments cut through the Medicare program by 21%, certainly likely to make that form of practice financially not viable. Furthermore, reforming the SGR is hoped to promote evolution from a flawed fee-for-service system toward more value-based payment and care. And thus, in 2014, around this time, The SGR fix was agreed to by key House and Senate committees. In our new paper appearing in Health Affairs today, we describe key features of the 2014 SGR fix. We place it in the context of both past and ongoing Medicare health policy, assess its strengths and weaknesses, and suggest further actions to ensure success in meeting policy goals. To facilitate timely discussion of this issue, Health Affairs has released this paper today so it can be found in your print packets or through the resources widget for our webinar audience. The paper will appear in the April print version of the journal. In recognition of the special efforts of Health Affairs to this discussion, I'd like to ask Sarah Dine, Senior Deputy Editor, to come up to the podium to kick off today's presentations. Sarah.
On behalf of Health Affairs, I'd like to thank Dr. Rich and Mathematica Policy Research for inviting us to participate in today's forum. In 2008, in a blog post for Health Affairs, Bob Berenson, who is a senior fellow at Urban Institute, paraphrasing Rodney Dangerfield, wrote, the SGR is, like him, getting no respect. For those of you who have no idea who Rodney Dangerfield is, and that's probably everyone under 50, you can look him up on Google. One can even ask how the SGR, like Rodney Dangerfield, became something of a long-running gag, a piece of legislation more observed in the breach than in practice, what one scholar referred to as a theoretical payment rate. As was shown before, and as all of you know, the SGR came out of the Balanced Budget Act of 1997, which coincidentally was the first year that James Reschovsky published an article in Health Affairs. And until 2002, 2003, worked pretty well, was relatively obscure and uncontroversial. Even in 2003, Tom Scully, who was then the administrator of CMS, in testimony on Capitol Hill, characterized it as uncontroversial and stable. This characterization did not last long. In 2004, Paul Harrington of Vermont, in a perspective in Health Affairs, quoting Glenn Hackbarth, then the chairman of MedPAC, said the SGR is widely recognized as being fatally flawed. Since then, Health Affairs has published articles, blog posts, and health policy briefs analyzing the defects of the SGR and proposing various remedies. The titles from some of the blog posts in the 2008 series give you a flavor of that discussion. Paul Ginsberg, now at the University of Southern California, titled his Bitter Medicine. Bob Berenson's subtitle was Making Sense of Stone Soup. Dr. Rich, who just kicked off this forum, wrote a post titled The Doc Fix, the Champ Act Approach to Medicare Physician Payment Reform, one of the many attempts to fix the SGR. In 2011, Jeff Goldsmith, president of Health Futures, wrote a blog post titled MedPAC's SGR Solution, Bad Medicine for a Chronic Problem. It has taken a decade of criticism of the SGR and of proposed solutions for a bipartisan consensus, both in the halls of Congress and the think tanks of Washington, for a solution to emerge. Starting at the end of 2013 and going into 2014, another series of blog posts and articles ran in Health Affairs about the emerging legislation just discussed by Dr. Rich to replace the SGR. These include an article by Gail Walensky in January 2014 titled Developing a Viable Alternative to Medicare's Physician Payment Strategy, and subsequent blog posts by John Rother, Joel White, and David Kendall, all representing healthcare coalitions, and another one by Robert Moffat of the Heritage Foundation. The bipartisan and bicameral bill, as noted by Jim in his paper, did not get enacted last year, but seems to be coming back to life this year. Health Affairs is pleased to be in the vanguard of presenting his work on this crucial piece of overall payment reform and to get the conversation rolling again. And as Dr. Rich mentioned, the article was released today at noon on the web, and I've been asked by my staff to hold it up. And it's will also be available in the hardcover April issue of Health Affairs. Thank you very much.
Thank you, Sarah. Now I'm going to briefly introduce today's panel of experts and the rest of our agenda. So Jim Reschovsky is a senior fellow at Mathematica and lead author and discussant of this health affairs paper. He contributes to an array of studies informing the health reform debate with a focus on... Very good. Little bobbling here with respect to the slides. He contributes to an array of studies informing the health reform debate with a focus on payment systems and care delivery transformation. Mai Hubbard, a senior researcher at Mathematica, will draw from her deep understanding of Medicare provider organizations and approaches to provider feedback, gained through leadership of such projects for CMS as value-based payment modification and Medicare physician feedback reports. She'll illustrate the diversity of practice settings serving Medicare beneficiaries and how these might relate to key elements of the SGR fix. Our next discussant will be Stu Gutterman, Vice President for Medicare and Cost Control at the Commonwealth Fund. We're grateful to the Commonwealth Fund for supporting Dr. Reschovsky's work that culminated in the paper being discussed today. Dr. Gutterman will reflect on the SGR fix from his unique perspective, drawing from his decades of Medicare policy work at the Fund, at CMS, at the Congressional Budget Office, and the Medicare Payment Advisory Commission. Finally, we're very pleased to hear from Bob Doherty, Senior Vice President for Governmental Affairs and Public Policy for the American College of Physicians. Mr. Doherty will reflect on the implications of the SGR fix for primary care internists and various medical specialists serving Medicare beneficiaries in many thousands of practice settings across the country. And now I'm pleased to turn the podium over to Jim Reschovsky. Jim.
Thank you, Gene. First of all, I'd like to thank Sarah Dine, Larry Wheeler, and Don Metz at Health Affairs for their incredible efforts. This paper was fast-tracked in anticipation that Congress might in fact fix the SGR before the end of this month. Whether that's going to happen is still an open question, but I just learned that, you know, there are still people on the Hill that think it might happen. They also made the paper much better and went beyond the call of duty to get the paper published online today. I'd also like to join Gene in thanking the Commonwealth Fund for their financial support, and especially our project officer, Stu Gutterman. The paper does reflect our views, not that of Commonwealth. And then finally, I'd like to acknowledge my two wonderful co-authors, Laura Converse and Gene Rich. So, as Gene indicated, the paper evaluates the 2014 SGR fix legislation, which most believe will serve as a framework for any action before Congress takes this year. The legislation would repeal the SGR and replace it with small but legislatively specified payment updates. Eligible providers could choose between one of two pathways. They could stay with fee-for-service, but with an enhanced two-sided pay-for-performance system called the Merit-Based Incentive Payment System, or MIPS, or alternatively, they could significantly participate in alternative payment models known as APMs. The structure of the legislation created incentives for choosing the APM pathway. Now, I'm going to use the shorthand of physicians in my remarks, but the legislation also applied to advanced nurses, therapists, and other clinical professionals. So the goal of the legislation, apart from getting rid of the SGR, is to move Medicare away from fee-for-service and to a more patient-centered, value-based payment and delivery system. And this gives rise to three key evaluation questions. First, Would MIPS improve quality and lower costs on the fee-for-service MIPS pathway? Second, will APMs improve quality and lower costs on that pathway? And finally, does the SGR fix provide ample incentives for physicians to choose the APM pathway, as well as sufficient APM opportunities for them? Now, there are not going to be any definitive answers to these questions. And in fact, the answers are really going to depend on the type of provider, the organization, and local market conditions. But what we do is we draw on the literature to provide analysis and perspective on these questions. But first, let me give you a quick Cook's tour of the 2014 SGR fix. This slide shows the two pathways. Alternative payment models include ACOs, bundled payment arrangements, medical homes, and any others that people might think up in the future. Now, to be an APM, certain criteria must be met, and for all but medical homes, there must be financial risk involved. That is, providers could lose or gain money if their costs fell above or below a benchmark value, respectively. Now, to gain passage on the APM pathway, there are minimum amounts of APM involvement or revenue that are required, amounts that grow over time. Now, under the 2014 SGR fix legislation, all physicians would receive 0.5% increase in fees annually for the first 5 years. Then for the following 5 years, there would be 0 updates, but those on the APM pathway would receive a 5% bonus to their fee-for-service reimbursements. Then from 2024 onward, APM pathway physicians would receive an update twice as large as those on the fee-for-service MIPS pathway, 1% versus 0.5% per year. Now, these years that I've been mentioning are from the 2014 legislation. Presumably, they would be pushed forward if Congress passed similar legislation this year. Briefly, let me now describe how MIPS works. It replaces 3 current programs: payment penalties for failing to report quality measures or for meeting EHR meaningful use criteria, and also the value-based modifier. In their place, CMS will devise a composite score based on 4 components that are listed in the middle column of this slide. Pay-for-performance payment adjustments are then based on how a physician's composite score compares with that of other physicians. MIPS kicks in 2018, and financial incentives grow to plus or minus 9% by 2021, with extra fee adjustments for the highest performers during the first 5 years. Now let's talk about the 3 key questions, starting with prospects of MIPS to improve care and lower costs for those remaining in fee-for-service. MIPS is also designed to encourage practice improvements and ease the transition to APMs. Now, the evaluation literature for pay-for-performance is mixed, and generally it doesn't give rise to great optimism. But MIPS is fundamentally different than most previous pay-for-performance programs, such that past history may not portend MIPS's prospects. So let me lay out several characteristics that I think give rise to optimism, and then several that might compromise MIPS's effectiveness going forward. First, The two-sided reward structure in MIPS, one where rewards or penalties are based on performance relative to others, may well prove to be a much more effective mechanism than the typical bonus-based P4P program. Moreover, the financial penalties and rewards are sizable, adding to incentives on providers. More resources are going to be put into development of quality measures, and performance scores will be made public on the Physician Compare website, something that could further incentivize physicians. Finally, Medicare is the largest payer in this country, and especially important for some specialties. MIPS may be far more influential than previous pay-for-performance efforts by single commercial payers. And it's also possible that other payers could well emulate MIPS, which would have the effect of magnifying the incentives to provide value-based care. But there are factors that might compromise MIPS's success. Meaningful and effective quality metrics are really difficult to develop. More quality measures does not guarantee quality improvement. The legislation does appear to be sensitive to these issues, but the proof will be in the pudding. There could certainly be some opportunities for physicians to game the system or even to select patients in order to keep their scores high. And finally, the complexity of the MIPS composite score could actually make it less actionable by physicians, while difficult technical issues involved in evaluating physician quality or physician's efficiency could compromise the system's credibility in the eyes of physicians. So now let's turn to the second key question. Will alternative payment models work to transform our healthcare system? There's general agreement that fee-for-service has some very negative effects. It increases costs and can compromise quality. It rewards unnecessary and expensive care. It fragments care delivery, fails to reward quality-enhancing activities. So rewarding providers for high quality and efficient delivery of services is seen as kind of a logical way to alter physician incentives. That said, the empirical evidence for APMs is mixed, though, there are some positive, promising results. Recently, HHS Secretary Burwell announced ambitious goals to expand APMs, tying, I think, 50% of Medicare payment to them by 2018. When we look at CMS's experience thus far with ACOs, accountable care organizations, there are some modest cost savings, but to date, few ACOs are close to being able to accept downside risk. With respect to medical homes, first-year results from 2 large multi-payer medical home pilots recently were released. One showed surprisingly good results, while the other showed some cost savings, but overall had much more mixed results. With respect to bundled payment, there are no reliable evaluation results yet from the CMS demonstration, but the literature on bundling generally points to cost savings. But despite this spotty record, I would not be terribly pessimistic. Transforming the care delivery system is not easy, and it's going to take a long time. There are integrated systems of care that exist right now that provide good outcomes at lower cost, but these organizations have been working at it for decades. Setting up an ACO, a medical home, a bundled payment arrangement is tough. It involves many steps, many of which are listed on this slide. All this takes time. Moreover, new care models often call for a new clinical mindset by providers, from one where the physician responds to the clinical problem in front of them to one where the physician is part of a team that proactively manages the constellation of a patient's health challenges. All this takes time, and major APM pilots from CMS are still mostly really early in the game. There are considerable APM activity by commercial insurers and state Medicaid plans, and that's another reason to be optimistic. Cross-payer participation in APMs allows for the fixed costs of transformation to be spread over more patients. Plus, there are likely to be spillover effects to patients not covered by APMs, as clinicians change their practice patterns to be in sync with new APM models. And now let's turn to the third question. Are incentives to get physicians to choose the APM pathway sufficient, and will there be opportunities for those wanting to go down this pathway? This, of course, is a difficult question to answer. Income opportunities under each pathway depend on the incentives in the law, but probably more so on how MIPS and APMs are implemented. Local market conditions, type and size of practice, specialty are also going to be important factors. Lots of physicians will go down the APM pathway or use MIPS to improve care simply because they want to do right by their patients. And many are going to take the APM pathway, begrudgingly or not, because they see it as a way, they see which way the winds are blowing right now. By and large, I think we should be encouraged by the level of participation and interest by the provider community in APMs to date. The 2014 SGR fix encourages some specialty and small practices. The SGR fix recognizes that some specialty and small practices may find it hard to get onto the APM pathway and directs resources to find APM options for these groups. There are already pilot demonstrations for ACO and bundled payment arrangements for ESRD patients, and interest in oncology and other specialist medical home models. Having said this, CMS does need to be careful, however, that efforts to create specialty-oriented or even condition-oriented APMs don't fragment care delivery and come in conflict with ACOs, which have a whole person population-based focus. I'd like to finish up with one area where the 2014 SGR fix is lacking. And this is really relevant to all three of the main evaluation questions. The physician fee schedule is supposed to be based on the relative resources necessary to efficiently provide each of 8,000 or so services. However, the fee schedule is very broken, with many services either over or undervalued, hence more or less profitable. Generally, this has worked to the advantage of proceduralists and against cognitive specialists, and especially against primary care physicians. This situation allows some physicians to maintain and grow their Medicare revenues despite low fee updates, by providing more high-profit services and fewer low-profit services. MIPS is going to lessen the returns on this behavior by as much as 2.7% because it penalizes high-cost physicians. But that may not be enough to discourage physicians from continuing to grow their incomes by taking advantage of the broken fee schedule. Fee schedule misvaluations encourage wasteful and poor quality care, could encourage wasteful and poor quality care on both pathways. This is because APMs are still built on a fee-for-service chassis. And continued underpayment for primary care providers will retard medical home transformation, and relevant to all types of APMs. The benchmarks that are used to assess whether a provider will be punished or rewarded for their cost performance are based on fee-for-service costs, costs that are distorted by our flawed fee schedule. I'm going to skip this slide and go to my conclusions, which are the 2014 SGR fix affords physicians some level of certainty with regard to Medicare fees, and it really rids Congress of what has become a political albatross. It builds upon current reform initiatives, and in doing so, helps to accelerate the move away from our reliance on fee-for-service in traditional Medicare towards systems that reward value in healthcare delivery. It is not the be-all and end-all, but definitely a move in the right direction. And as I've indicated before, CMS will need to be agile in adapting MIPS and APMs over time to ensure success. Now, one thing that our paper does not venture into is the political minefield of whether and how to pay for the SGR fix. The cost is high, but it's small in relationship to the total cost of Medicare, and possibly it's small in terms of the potential for savings over the long term. So I look forward to our discussion at the end of the presentations, and now I will give the podium over to Mai Hubbard. Thank you.
Thank you so much, Jim. So today I'm going to be talking a little bit about our experiences on the ground from a program that is currently implemented under the law. And this is the Physician Feedback and Value Modifier Program, which I'll refer to from this point on as the Physician Value Program. This is a program, as Jim noted, is a component of the MIPS. That is, it'll be in addition to the EHR meaningful use, as well as the PQRS programs, something that could feed into the MIPS. But much of what we've learned on the Physician Value Project has much of relevancy to some of the legislation's two priorities. The first priority that I'd like to address in this discussion is going to be about how the APMs should be encouraged to test for specialty physician services, as well as professionals in small practices of 15 or fewer eligible professionals. And the second legislation priority is to address the challenges and vulnerabilities of APMs. To provide some information that may be relevant to the legislation's first priority, what I'm going to be doing today is to discuss very briefly, provide some background about the Physician Value Program, and then I'll move over to some findings that we've been able to analyze using the Physician Compared database. So what is the Physician Value Program? For the past several years at Mathematica, we, along with our colleagues at Northrop Grumman Corporation, have been implementing the Physician Value Program to assist the Centers for Medicare and Medicaid Services with distributing feedback, confidential feedback reports to solo practitioners as well as groups of physicians. We should note that this program has very much been a phased-in process. In 2009, when reports were initially disseminated, we sent approximately 300 reports to physicians and physician groups. Last year in 2014, we disseminated approximately 300,000 reports, and these were to all physicians and physician groups nationwide. The purpose of these feedback reports is to provide both quality information as well as efficiency information about the kinds of care, efficiency in which the care is provided to beneficiaries to these groups. And the second part of the law requires that physicians starting in 2015 be evaluated based on these quality and cost metrics and then have their payment, Medicare physician fee schedule payments modified. In 2014, currently, using these performance metrics, groups of 100 or more eligible professionals are being impacted today. And this, again, will be phased in as we expand out to 10 or more eligible professionals. And finally, by 2017, the plan is to have all physicians impacted by the value-based payment modification. I should note that I use the term group practices in this presentation, but for the purposes of the Physician Value Program, groups are identified using their tax identification number. And moreover, one of the key things to note here is that the assignment algorithm of beneficiaries to group practices is going to be quite critical in making sure that we assign the patient group to groups appropriately. One of the primary ways in which we do so under the Physician Value Program is to use a primary care services focused attribution process. In this attribution process, I won't go into much detail. It is required that a beneficiary receive a primary care service from a physician in order to be assigned to an actual group. So let me take go through some of the findings from the physician value, from the QRURs that were disseminated in 2013. That year, we disseminated approximately 6,000 reports to groups of 25 or more eligible professionals. So it should be noted that these were pretty large groups. They represent about 20% or 6,000 of the 300,000 or so groups that are eligible to receive reports this year. Among these, 1,000 or 1/3 of groups were large groups of 100 or more eligible professionals. And then, one of the more interesting findings was that 1/4 of the groups that received reports were major single specialty groups. So what that really means is that a specialty dominated that group, one single specialty dominated that group, where 50% or more of the group was comprised of one specialty. Among those, 30% were primary care physicians, and another 70% were non-primary care physicians, such as anesthesiologists or dermatologists. So as mentioned previously, the 2012 QRURs had a primary care service-centric attribution process. And so it was not surprising for us that larger single specialty groups that provided non-primary care services, such as anesthesiologists or radiologists, were less likely to be able to receive a report back in 2012. To that end, many of the groups that didn't receive primary care services and like radiologists and anesthesiologists now have an opportunity to receive the QRURs, given that the CMS Physician Value Program not only accounts for one attribution process, but does have multiple attribution processes in place to be able to take in, to calculate both cost and quality metrics. Now, to that end, the development and testing of APMs may focus on how larger groups, larger groups, there continues to be many single specialty groups to which we'd want to promote high quality and efficient care. So again, as Jim also alluded to, there might be a direct focus toward the impact of the organization's specialty structures as APMs are tested. I'm going to move away from the findings from our QRUR dissemination and move to an analysis of the physician compared database. This analysis focuses on smaller group sizes of 15 or fewer eligible professionals. So what we've learned about taking a look at smaller practice groups is that there's great variation in the organizational structure of smaller practice groups, like we saw in larger groups. The exhibit here shows that for several specialties, the percentage of the physicians that work as solo practitioners, and it's shown in light blue in this slide, and groups of 15 or fewer eligible professionals, shown in dark blue in this slide, vary quite a bit. So for example, if you take a look at the dermatologists and ophthalmologists who are in the upper two rows of this exhibit, you'll see that about 25% of them work in solo practice settings, whereas about 70% of them work in groups of fewer than 15 eligible professionals. In contrast, diagnostic radiologists, for example, have less than 27% in a group of fewer than 15 eligible professionals, and 2% of them work as solo practitioners. Now again, although these statistics are very much high level, these findings allude to the potential need to pay particular attention to the testing of APMs to specialty physicians, and moreover, the organizational structure of those specialty physician groups. So again, single specialties as well as small practices dominate for some of the specialty groups that I've shown here today. I'm going to come back to the original discussion about the SGR legislation's priorities and bring us to the second priority of the legislation, which is to identify potential challenges as well as vulnerabilities to the testing of APMs. Obviously, I'm not going to be able to be comprehensive in the challenges that we can expect, but there are a couple of things that I'd like to highlight from the physician compare analysis as well as some of the experiences from the physician value program. In particular, what we do know is that a lot of physicians practice in multiple groups. For the Physician Value Project, for example, what we do when a physician practices in 2 or more organizations is that they are evaluated separately across those 2 organizations. Whatever they do in one practice setting will then affect how their physician fee schedule payments in that practice setting, and that's separate from another practice in which they might be working. For the physician compare database, we see something very similar in that specialists who work in multiple groups is quite common. Cardiologists, ophthalmologists, diagnostic radiologists are some examples where a majority or over 50% of them work in more than one setting. Moreover, what we've seen is that there's quite a bit of variation for those groups for those physicians that do practice in multiple settings in the size of the groups in which they practice. So again, we're taking the example of dermatologists. Among those who practice in multiple settings, about 20% of them are going to be solo practitioners compared to radiologists, who we saw previously as well, who didn't work as often in solo practices. They too work in multiple settings as well. Only 1% of them work in multiple settings here as well. So again, one of the design challenges that we will want to consider as we think about APMs is how will the APMs impact the organizational structure of these TINs? For example, could APMs result in the shift of physicians to a more multi-specialty organizational structure? Or could physicians rethink the way they practice under multiple TINs? So those are the questions that I'd like to leave you with here today. And so to quickly summarize, I went through a very quick overview of the Physician Value Program and some findings from our Physician Compare database to provide you with a better understanding of how organizations of specialties and smaller practices are designed currently. And applying the APM to these types of practices, both single specialty as well as smaller practices, is going to be complex. We'll really want to identify what the impact of implementing such APMs are going to be to the organizational structure of these groups. And I'd like to thank my colleagues who've worked on this project with me for very many years, Jeff Ballou, Will Lim, Jean Rich, Mike Rudisell, and Amy Valenzuela, and many, many more here at Mathematica, as well as my colleagues at Northrop Grumman. And a big thank you to Anna Collins, who helped to make this presentation a success. Thank you.
Now, Stu Gutterman.
Thanks. I'm here.
put your PVC. There you go.
Okay, is that better? Good, okay. So I want to talk about, remind people why the SGR is a target for legislation. Let's go back to actually 1989 when the resource-based relative value scale, the current physician fee schedule, was put into effect or legislated, and it went into effect in 1992. And there was concern because there's a saying that the most expensive medical instrument is the physician's pen. There was a concern that if you were even with a fee schedule as opposed to paying reasonable charges, you would still have a strong incentive to prescribe more services, and that would push Medicare physician spending up. So it was felt that there needed to be a limit on that. And initially, a volume performance standard mechanism was put in place that kind of did what it sounded like. It adjusted the fees relative to what happened to volume and intensity over time. But it was felt that that system was unstable after a while, and so it was replaced in 1997 in the legislation by the current sustainable growth rate mechanism. But the idea was the same, and it was an understandable idea that physician spending should be governed by how much money we had to spend on physician services, and that meant that it was tied to the growth rate in GDP with some adjustments based on policy changes. That's understandable in terms of establishing a target. The problem was that while volume and intensity were seen as the threats to physician spending, the SGR, as the VPS before it, cut physician fees in response to that. And it's a little bit like holding a gun to your head and saying, "Stop or I'll shoot." Because you can reduce fees, but that's still, in fact, if anything, going to create more of an incentive to increase volume and intensity. That was what led to a problem. In the initial years, everything was actually pretty hunky-dory because GDP was growing very rapidly in the late 90s. So the SGR mechanism produced very generous increases in physician fees, and everybody was happy. The problem was when GDP started growing more slowly, and also there were a couple of technical issues that had to be corrected in how the SGR had been calculated in the early years, and that led to a series of negative adjustments produced by the SGR formula. And after 2002, when Congress actually let a 4.8% cut in physician fees happen, in every year since then, Congress stepped in at the last minute, and sometimes, in fact, after the last minute, to prevent that from happening, because nobody wanted to see an across-the-board cut in physician fees. Now, how effective was that? Well, in the early years of the SGR, we had an average of a 3.8% increase in physician fees each year, and Part B spending per beneficiary went up at an average of 7.3% a year. So it was clear that the high the high increases in physician fees were leading to high increases in spending in Medicare. In 2002 to 2007, with a series of averaging zero updates, Medicare Part B spending per beneficiary rose at 8.4% a year. So point number one is it's clear that the SGR is not an effective mechanism for controlling physician spending. In the years since then, we've actually had some moderation in physician updates, and of course, an extreme moderation in the growth in Medicare spending. But there's still no strong evidence that that the SGR has had the effect that was that it was intended to have. Although there are some people who say, well, but if we got rid of the SGR, we would end up with even more spending. We of course don't know about that. So that's one failure of the SGR. There are a series of other failures that are listed here, and I think it's important to go through them all because people need to be reminded what it is we are facing as an alternative to repealing the SGR. And one is that you are talking about cuts in payment rates across the board. So good physicians and bad physicians, physicians who perform inappropriate services, and physicians who really focus more on providing only appropriate services. They all get the same cut. It also maintains the incentives for physicians to increase service volume intensity, because if you're being paid for volume and intensity, you're going to, even if you're being paid less for volume and intensity, you're still going to try to maximize volume and intensity. It also doesn't fix, the RBRBS was put in place to correct the overemphasis on procedures as opposed to diagnostic services, and it did that somewhat, but over time that effect has kind of deteriorated, and you still have, as Jim pointed out, services that are undervalued and overvalued in the physician fee schedule. It obviously has not succeeded in controlling spending growth. It did lead to increasing gaps between Medicare and private payment rates, which puts access for Medicare beneficiaries at risk, especially if the massive cuts that the SGR produces ever get put into place. You're going to find a real problem with Medicare beneficiaries having access to physicians. It has undermined Medicare's credibility with physicians because every year physicians have to worry about whether they're going to have this 20 or 25 or 30% cut across the board in their physician fees from Medicare patients. We've had instances where physician practices have handed out letters to their patients saying we can't continue to provide the services that you're used to us providing if this happens, because we're just not going to be paid to provide these services. And it lacks any incentive to improve quality, appropriateness, or coordination of care. So that's what the legislation that was considered last year and passed unanimously in both houses. And how many occurrences of that can you count in the last few years? Why that legislation was passed. So in December 13, we had a fire sale on the SGR. CBO came up, because of the slower rate of growth in Medicare spending, CBO came up with an estimate of $116.5 billion as the cost of freezing physician fees across the board for 10 years. So even that would, quote, cost $116.5 billion. I put cost in quotes because everybody knows that Congress is going to defer the cuts that are produced by the SGR formula. So the question really is whether it's an actual cost to the federal budget or just something that that the law says to ignore until Congress decides to defer those cuts. One might think of another way of approaching budgeting in this instance, which I might refer to as a common law baseline. CBO uses a current law baseline. You know that in many jurisdictions, when couples cohabit for a period of time, they're considered common law married. I would propose that CBO could consider that the third time that Congress defers legislation from actually taking effect, it could embed those costs forever in the baseline and call it a common law baseline. So the House Energy and Commerce Committee, the Senate Finance and House Ways and Means Committees all passed bills very similar in nature, and unanimously, again, bicameral, bipartisan agreement. But the problem was, again, the cost of SGR repeal, even though the SGR was on sale at the time. In March, late March, Congress deferred the physician fee reductions again for the 17th time since 2003. In February last month, CBO revised its cost of repealing the SGR, and it went up a little bit, and that usually happens because you're shifting the years that the estimate applies to $137.4 billion. Again, this is just the cost of freezing physician fees with nothing else for a 10-year period. To paraphrase President Reagan in his campaign in 1980, here they go again. That's the story, and that's why we have to think about this. One speaker at a meeting that I was at said to congressional members who were in the audience, you guys have to understand that the alternative we're talking about, the system we have now, wastes money and kills people. What is it that we're afraid of getting rid of? So we really have to think that way. Thanks.
Very much, Stu. Now, Tom Doherty.
Thank you and good afternoon. It is a pleasure to be with you. I'm going to represent the perspective of one of the major groups in organized medicine that has been dealing with this issue more than I want to think about, the American College of Physicians. For those who aren't familiar with ACP, we are the largest physician specialty society in the United States with 141,000 members. And I think we're also distinctive because we represent both primary care doctors, general internists, but also all the medical subspecialties. So we have everybody from general internal medicine that does no procedures to basic cardiologists. So when we look at these things, we try to look at not just at the impact on primary care, but also our subspecialty members. So the question I want to address is, what's our perspective at a macro level on the SGR legislation? Do we think this will advance things in the right direction? But then I'm going to try to bring it down to a micro level, to how doctors are looking at all these changes and their anxieties and their concerns. Let me start out by saying we do support the legislation that was reported out on a bipartisan basis last year by the Medicare authorizing committees, the Medicare SGR, Medicare Provider Payment Modernization Act, for several reasons, and you heard many of those from the previous speakers, but I want to emphasize several. One is it does repeal the SGR and provides a transitional period. That was very important because physicians are at different places in terms of their ability to become part of an alternative payment model for new quality reporting. It provides stable, albeit small, updates during that transition period. It consolidates existing Medicare reporting programs into one merit-based incentive program. And that's very important because physicians complain about having different rules, deadlines, and penalties for the different reporting programs. And it actually has a provision in that call for measure harmonization, not only within Medicare's reporting programs, but with the private sector reporting programs. And very importantly to us, we think there is solid evidence on the effectiveness of patient-centered medical homes with certain attributes. And it provides in their merit-based incentive program that if you are a certified medical home, you would automatically qualify for the highest possible score for the quality improvement part of this program, which is about 15% of the total score. It offers pathways, as you heard from the other speakers, to alternative payment models with opportunities for shared savings supported by higher annual fee-for-service updates. And again, the medical home is treated somewhat differently because unlike other models that we have to accept both upside and downside risk, medical homes in this legislation would have to demonstrate they could improve quality without increasing costs or save money without hurting quality. And we thought that was very important and something we supported. We also, while this is all going on with the SGR, of course, you've got Secretary Burwell's announcement about setting some ambitious goals, historic goals, to transition Medicare payments to value-based payments within 3 years. So that's the macro level. And we're encouraged that actually right now we heard today that there are discussions in the House leadership about actually advancing SGR repeal legislation based on last year's bill before the patch expires at the end of this month. But taking it down to micro level, I think what we have to be careful about is that as we move towards value-based payments, we don't add to the big squeeze on physicians and patients. And this is a cartoon I found on Twitter. I thought it was wonderful. This is a poor doc being squeezed by algorithms, scorecards, patient satisfaction, RVUs. You can read it all. And I hear that universally when I talk to physicians. And interestingly, it's not just physicians in small independent practices. Even physicians in large group practices talk about being squeezed by all these external reporting requirements, rules, algorithms, and so forth. And I think fundamentally, if we don't address that, all this talk on a macro level of moving to value-based payment models is not going to work. But it's not just physicians being squeezed, patients are being squeezed. ACP did a study looking at how much time unnecessary time physicians spend in terms of entering and retrieving data from electronic health records. And we came up with a mean loss for attending physicians was 48 minutes per clinic day, 4 hours for 5-day clinic week. So EHRs, which are supposed to be a tool to improve quality, improve documentation, and help physicians report seamless and quality measures, actually is diverting time away from patient care. It also leads to more expense. This is a study that was published in Health Affairs back in 2009 that actually tried to document how much time physicians and their staff spend on dealing with interactions with insurers, not just Medicare, but all insurers, and then actually put a price tag on that. And you can see it's enormous. It's enormous. Physicians spend an average of $68,274 per physician per year interacting with health plans. Think about what that money could represent in patient care. Or even we talk about reimbursement rates. If you're a primary care physician, you're spending $60,000 in administrative costs. That's equivalent to a $60,000 net loss of income. So again, it's a huge problem. So what do we do? What should you do about it? And I would say that in the context of the SGR legislation, let's start with several things. We need to prioritize, simplify, and consolidate measures, focusing on core measures relating to high-value care and streamline reporting requirements for both public and private payers. Internal medicine, you hear some specialties don't have any measures or good measures. Internal medicine has plenty of measures, but there's so many of them, and payers don't even agree on which measures are the most appropriate or relevant. So you need to prioritize and streamline measures. The SGR repeal bill is potentially a step in the right direction, but it could add to the big squeeze if reporting detracts from patient care, piling on more measures, more reporting requirements that physicians don't find meaningful. Number two, we need to improve EHRs and meaningful use, focusing on clinical documentation, clinical decision support, and reporting and measures. Number three, we need to reduce the hassles associated with third-party utilization review for physicians in more advanced risk-bearing alternative payment models. If we move to APMs where physicians really are accepting upside and downside risk, where they have to show the effectiveness of the care they provided, the justification for much of the micromanagement that exists in a fee-for-service program should go away. Why should we need pre-authorization for advanced imaging if you're going to be paid based on the efficiency and effectiveness of your care? So let's get that quid pro quo. So if you're in these APMs, let's not just talk about bonus payments of the fee-for-service, relieve the administrative hassle. We need to be careful where we set the bar for APMs. If you set it too high, we'll incentivize physicians to remain in fee-for-service while still adding to practice burdens, and the APMs may fail to achieve quality efficiency gains, though, if we set it too low. And then on fee-for-service payments, we do need to improve fee-for-service. It will still be the underlying methodology for many of these other models, and we certainly agree with the recommendation to fix inaccurate RVUs. But there's going to be limited opportunities to do that, partly because the SGR legislation set target reductions in RVUs, the targets to reach for the RUC. And if they met those targets, physicians got to keep the money. If not, half the money was taken out. Well, Congress already used that for the patch last year and for the ABLE legislation. So it's diminishing returns of what you can get simply by redistributing RVUs. Another way to go about it is to begin paying doctors, particularly primary care doctors, for the service they provide outside the face-to-face encounter. And CMS has started doing that with the new chronic care management codes, which went online on January 1, the transition to care management codes that went online last year. And then finally, Congress needs to first do no harm to fee-for-service. We already had the Medicaid primary care parity program expire on January 1, which is a big cut to primary care doctors seeing Medicaid. And the existing Medicare 10% bonus program for primary care expires at the end of this year. Think about that. Primary care doctors would get half the cut they get from the SGR on their office visits if that program expires at the end of this year. In conclusion, the SGR repeal legislation offers a realistic pathway to fundamental physician payment reform. The bill can be improved, but too many changes will upend the almost universal support within the medical profession. An SGR repeal is essential. CMS should not wait for the Congress, though. There are a lot they can do within the current authority under the Center for Innovation. And as we redesign physician payments to achieve value, we have to be careful not to further put the big squeeze on physicians, especially those in primary care, by adding more requirements that take time from patients, add to practice expenses, and contribute to burnout. Thank you.
Thank you very much, Bob. And thanks to all of our presenters. And I certainly have lots of questions that I would like to ask and discussion here, but really I'm here to moderate the questions, comments from the audience here in the room and on the webinar. So let me start by asking here in our audience, does anyone have an opening question or observation? And we've got microphones here. Okay, well, I'm reluctant to call on people, although I see several people in the audience who I'm sure have opinions. So we have some questions from the webinar, so turn to Crystal.
All right. We have a question from Amanda Nayrod. In CMS's proposal to shift physicians into alternative payment models, is this ambitious given the outlined time frame?
All right, we've got several folks who could speak to that, so Jim can start.
I would say that there's one component of the incentive structure that does worry me. It does give this 5% bonus over a very defined period, 5 years out for 5 years, essentially. And it's going to be the fact that different physicians, different groups are going to get to that point at different times. And some are not going to be able to take advantage of the bonus payments. So it's possible that some other structure could be devised to give providers the extra help when they actually need it, rather than have a set calendar-based period when bonuses are available.
It looks like both Stu and Bob have thoughts on this question.
Well, I think my answer to the question would be yes, it's ambitious, but when you're setting targets, you don't want to set them too cautiously, because then you aren't convincing that you're actually going after what you're saying you're going after. And as Bob pointed out, providers really have been stuck in this position where they've got one foot on the dock and one foot on the boat. And they've been asking, just tell us which boat to jump in already, and we can adapt. There are ways to adapt for smaller practices and rural practices and others who are in situations where they might not be able to shift as quickly as other places, but they need to be ambitious because they need to set their sights high.
Yeah, I think it depends. I mean, I think there are a lot of physicians who already have taken the plunge, are actively engaged in whether it's medical homes or ACOs, and if anything, they're kind of impatient because they feel that the incentive structure is not yet there. I talk to a lot of physicians in very advanced medical homes who say, I've invested a lot of resources, but I get no additional payment from Medicare unless you're in the Comprehensive Primary Care Initiative, which is rolling this out in 500 practices in 7 markets around the country. So what I hear from them is they would love to see that Comprehensive Primary Care Initiative more broadly disseminated through the Medicare program, which the Center of Innovation already has authority to do. The other point I'd make, the 5% additional fee-for-service payments are a motivating factor, but that's not going to be the biggest driver. It's the underlying payment mechanism for the model itself. So for example, yes, if you're in a risk-bearing APM, you get 5% additional fee-for-service payments, which is going to incentivize people to some degree. But what really will incentivize them is the opportunity for shared savings, or if you're a medical home, if you're paid a per patient per month capitation fee on top of your fee-for-service. The intrinsic underlying payment methodology, I think, will be the bigger motivator than the fee-for-service add-on.
Also, one more point. We talk about incentives as though they're kind of bribes, but the real way to look at incentives, I think, is to look at moving towards systems that pay for what we actually want to see the healthcare system produce. And to paraphrase the old saw about parenting, if you're not paying for the right thing, you're paying for the wrong thing. And I think they need to move to paying for the right thing. And physicians will respond if you pay for the right thing. They've certainly responded from paying for the wrong thing.
getting a little feedback in here, but all right. So, Tim.
That's a question for Bob, and then others can... Yeah, a question for Bob, and then others can comment as well. In terms of the range of specialists, is there a variation? Can you make any comment about the variation of perspectives that some of your specialist groups have about their participation in APMs and other different places?
I think there is, and certainly even between specialties, and then within specialties, depending on whether you're in a large group practice, smaller system, there's a lot of variation in all of medicine, which I think is part of the challenge that you heard from the other presenters in trying to come up with models and pathways that work for everybody. Within internal medicine, I think if you're a general internist, or you're one of the internal medicine specialties that are principally, quote, cognitive. I don't really like the term because everybody thinks, all physicians think. But due to the E&M, principally your livelihood is based on evaluation and management codes. That would include endocrinology, infectious disease, etc. They're, I think, less invested in fee-for-service because fee-for-service really hasn't worked very well for them. Because in a fee-for-service system, you pay per unit of service, and even if you tweak the RVUs, there's only so many patients you can see per day, so you can't really just increase volume. But on the other hand, we have some invasive cardiologists probably who do pretty well on the fee-for-service, and to incentivize them will be a little different set of incentives than for generalists. But coming back to the point I made earlier about the sort of hassle factor squeeze, even more than the money, the thing I hear from physicians in the trenches, particularly primary care, are just feeling overburdened by everything that they feel takes away from patient care. And that's, again, my caution about as we try to design these new models, they shouldn't add to the burden, and ideally they should reduce that burden.
Do we have we have another question from the...
Hi, Paul Cotton with NCQA. None of you mentioned the provisions in the bill that apply to patient-centered specialty practices, which are very much the same as the provisions for patient-centered medical homes. Bob, this was very much a program built on the ACP paper for medical neighborhoods. How much does that address the concern that some of you raised about bringing in the specialists into the alternative payment models?
Well, what I can say is the provision of the legislation under the MIP side, the Merit-Based Incentive Payment System, where it calls for certified medical homes. And by the way, it does not define any certifying body or entity. The Secretary would develop some standards or process. But for certified medical homes to get the highest possible score for the practice improvement part, which is 15% of the component, the language applied both to primary care but also specialty medical homes. So that was a specific reference to so the medical home neighborhood, specialty medical home model could also qualify if they met certain standards. I think I'd have to look at the language. I believe that the language is not restrictive for them to qualify under the alternative payment model side for the more advanced medical home model.
Right, I would interpret my reading of the legislation, I would interpret it as saying that if a medical home model met the CMMI national implementation standards, then it could be implemented without downside risk. But that would mean that there had to be a model that went through a national evaluation and achieved that threshold. It sounds like there's a question from the webinar. Crystal.
We have a question from Marcia Schofield. What can you say about the impact of SGR reform on non-physician Medicare providers covered by the physician fee schedule, such as registered dietitians, physical therapists, or social workers?
Jim, I'll let you take that first, then I can pick up on it with mine.
Okay. I mean, I think that's a good question, and I think in many ways the types of interventions have been sort of physician-centric in terms of how the legislation was drafted. Nevertheless, there are certainly opportunities for these professionals, either as part of larger organizations, larger physician practices, or independent practices, to participate in APMs or participate in the MIPS program. But I think you do highlight a point where there are going to be some eligible professionals who are going to struggle to find the right pathway to onto the APM.
I mean, the language, anybody who's paid under the Medicare physician fee schedule would fall under the merit-based incentive payment program and the alternative payment model pathway. So it is broadly, it's not just, we tend to use a shorthand of physicians, but it's anybody who's paid under the Medicare physician fee schedule. The other comment I'd make is almost all APMs, their success will depend on team-based care. It's not just physicians. You have physicians working with advanced practice nurses and dietitians and nutritionists and others to get the best possible outcome. And that's where I really think you'll break down the silos, we hope, so that people are working as teams to get the best outcomes.
And it is certainly the case that all of those eligible professionals who currently bill through the Medicare fee schedule will get a 21% per fee cut come the beginning of April if there isn't something done. So that will be unpleasant, whichever certificate you hold. And as has been pointed out, there are indeed a variety of professionals in addition to physicians who can be directly engaged by alternative payment models. The one that's most obvious are nurse practitioner-led medical homes, which certainly could also be, certified and are being tested as we speak. Yes.
Nancy McCall, I have a question for Bob. The development of the reports that will decide if physicians get incentives or if they get penalties require a lot of technical considerations about the TIN, what unit, the attribution. What is your feeling about kind of where that is in terms of being a robust sort of effort and ability to capture what's actually that practice is doing, and therefore getting a fair shake at a bonus or bonus if possible?
I think that's a good question. I think, and Jim, I think addressed that in the article. It's not real good. It's not real good. There's so many technical issues from attribution, to the measures to getting timely feedback. That's one of the complaints you get all the time for physicians is, if you're going to be based on your value, your efficiency and the effectiveness of your care, you need to know how you're doing, and doing compared to whom or what. And CMS's technical ability to provide that kind of timely feedback, I think, has been problematic. Hopefully, though, through the Center of Innovation, we're learning what can be done to improve that. And it's interesting, even within a particular program like the Comprehensive Primary Care Initiative, which is the Advanced Medical Home Program at 500 practices, 7 markets around the country, I've talked to physicians in that program, and some actually have been pretty pleased about the feedback and the data they're getting, and others have been frustrated. And that's the same program, and I'm not quite sure why that variation exists, but it exists even within one of the programs funded by the Center of Innovation.
Yeah, and to follow up on that point, I'm tempted to direct a question to my Hubbard, but because she has learned a lot about how specialties and practices relate to tax identification numbers, but much of what she's learned is not in the public domain. And so I, having been a former manager of a large multi-specialty group practice that lived off the Medicare program, thank you very much, internal medicine and its subspecialties, we'll make a couple of observations, and that is that in some of our analyses, we found some intriguing, if not alarming, disconnects between how physicians report their specialties in PICOS, which is the system that is used to identify physicians' specialties and attributed physicians to tax identification numbers. All of this available on the Physician Compare website at CMS. And an alarming disconnect between that and those physician specialties as recognized, say, by the numbers recognized by the AAMC, or even looking them up by me because I employed them or I knew what they were board certified in. The fact that there are a lot of interventional cardiologists out there who are not listed as interventional cardiologists in PICOS creates one set of problems. The fact that there are also specialty physicians who, the total number of cardiologists listed seems to be larger than the number who have been trained and certified in cardiology, creates some interesting problems and some opportunities, shall we say, for reporting your relationship and your practice style to the Medicare program, all of which would need to be sort of cleaned up and addressed in order to make sure that these alternative payment models and MIPS performance measures work appropriately. I don't know, Bob, if you want to reflect on any of those issues from the point of view of how physicians in practice are thinking about this presently.
I mean, I disagree. I mean, it's very variable. It's just, you'd think that there would be, I guess it's not simple. Simple way for physicians to know what they're being evaluated on, know which patients are being attributed for that purpose, know how they're doing, and to report on how they're doing. But it's enormously complex.
Yeah, I would agree. I mean, in addition to the attribution, there's the whole issue of risk adjustment. There's the problem that very often we're dealing with a small number of patients. And this not only feeds into cost performance and things like that, but also quality evaluation. You know, ideally you would like to have quality measures that focus on, did the patient get better, on the outcomes. And it's nice to say, but it's hard to do. And very often we defer to kind of process measures that perhaps are easier to measure given the data that are available, but don't necessarily relate very well to how well the patient ends up doing or how good the doctor is. And these are very difficult problems. It's not like we should run away from them, but we should acknowledge the limitations.
Let me add that we can't run away from them because many of these problems are problems in the current system. If you don't know how you're doing, that's a problem no matter how you're paying physicians. Yeah. Now one could maybe think of a rating wisely campaign, you know, where physicians come up with ways that they should be rated, that they think, you know, they view as success in their own specialties. There are lots of ways to do this, but the fact that quality measures are being discussed is a decision that was made, and before that, there were no quality measures being collected, and there was no knowledge about the quality of the healthcare system, and people were routinely saying, well, the U.S. has the best healthcare system in the world. We must, because we spend 50% more than any other.
Yeah. I mean, you know, physicians choose the measures that they get evaluated on, and they help in the legislation develop the quality measures. I think one needs at times to be careful that we're not putting ourselves in a fox in the hen house kind of situation, but nevertheless, you know, we certainly need physician input because they really know how best to evaluate themselves.
And let's also distinguish between the importance of evaluating the output of the healthcare system from the importance of regulating how that healthcare system achieves its output. Because I think that's frequently confused, and I think there's a big difference. I think we have a right to expect that the healthcare system produce uniformly excellent results. We don't necessarily want Baltimore to be managing the healthcare system in terms of how it achieves those results. I think we need to give providers a chance to try to achieve them if we send clear signals about what it is we're expecting them to achieve. And, you know, this is a process. We're on the road to that process, and we weren't on the road to 15 years ago.
I'll say one area of the bill that actually ACP has had concerns about, and we do support the Medicare, SGR repeal and Medicare Provider Modernization Act, has to do with the measure part. The bill provides pathways for measures to go from specialties to the Secretary without going through the NQF validation process. And although the NQF is not by any means perfect, it is a multi-stakeholder, pretty transparent process to look at measures to make sure they meet certain standards. And ACB is concerned about creating alternative processes where maybe there's less rigor by bypassing the NQF. So that's something that we actually would prefer be modified in the next version of legislation. I don't know if it's going to be politically possible, but we have a concern about that.
Yeah, but I think what folks have emphasized here is that while CMS and CMMI are already gearing up to implement and test a broad array of alternative payment models, the ones that Jim has already mentioned and others. Passing this legislation creates a variety of mechanisms and some additional resources that CMS and CMMI can use. So this really would be a fundamental sort of improvement in ways to move payment reform forward, as Jim points out in his paper. Yes.
Hi, Mary Wheatley, Association of American Medical Colleges. And I've heard this talk a little bit up front about, can you speak to the perspective of measuring this and implementing this at a multi-specialty group level versus the perspective from the individual? Because we work a lot with the multi-specialty group practices. And honestly, you get very different perspectives depending on where you're talking to and how these programs get implemented, the choices, whether you have choice in your measures, and just talk a little bit about how that piece needs to get resolved. Again, it gets into the types of practices, but we haven't really talked about the large specialty group practices and how that interfaces with the individual clinicians underneath it.
Are you asking specifically with regard to quality measurement or participation in APMs?
I mean, I think it's both, right? So part of it is we can talk about the quality measurement and how it's talked about through the value modifier, which we've had lots of conversations about that. I think when you talk about the alternative payment models and you're having to get to a certain scale, and then you're trying to say, well, how do these different programs within the same institution align together, right? So you're not just doing one program, maybe you have to do, that's just, I'm just curious to get a few thoughts on where people are thinking in that space.
So Mike, clearly the program you're involved with has been involved in several years and several rounds of providing feedback to large organizations which are typically multi-specialty. So I don't know, first, if there's anything that you feel like you can say on that topic based on what's been CMS has learned thus far.
Right, so I think one of the things to note here is that we try not to when thinking about multi-specialty clinics, we're not trying to identify just those multi-specialty clinics that provide primary care services. For example, for the VM program, it tries to expand its program to be able to incorporate all types of physicians, even those that are specialty specific. And so, I don't think we received, I should say the PQRS measures, I think because they are reported by the physicians themselves, what we've noticed is that they can pick their own measures, elect those measures, and report on what they think that they should be reporting, and that's sort of taken favorably by those by multi-specialty physicians. I'm not sure if that necessarily answers your questions in terms of what.
There's a lot of connections as to when you get to the big squeeze and you talk about how you create a system out of it. I think just knowing the unit of measurement, you get different perspectives, right? So I mean, I would actually argue that group practices don't get to choose what they're reporting on. They're a very limited number of choices that they have to make. And I'm just, so it's just one of those things that when you're looking through the different types of practice dynamics, I think, how does that all fit together with the alternative payment models and having potentially different sets of models that you're trying to resolve within the same entity?
Well, perhaps, given the fact we have 1 minute, sorry, Jim, perhaps we may want to engage about this a little bit after the formal presentation is over. I will also make the observation that one of the things that we've thought about quite a bit is also, are physicians in or out of these large organizations, particularly given the number of them that are billing out of multiple TINs, and how is that going to relate to trying to create a coherent accountable care organization in a big academic medical center, for example. But all of that we think is upcoming, and we'll be touching on some of these issues in some future issue briefs and papers on these topics. We've been working away on, after the doc fix, what are the policy research issues for implementing these Medicare alternative payment models, particularly for these small and specialty practices. Challenges to supporting and evaluating provider payment reforms and lessons learned by various projects here at Mathematica. Improving measures used in pay for performance for clinicians, work that we've been doing here for a number of years. And then Nancy McCall on how fixing the Medicare fee schedule impacts value-based purchasing and where we need to go in order to do that fundamental piece of additional work. So watch for this, this material coming out in the coming months and future forums that we'll be scheduling and announcing. I want to thank all of our discussants. Thank you very much to the discussants and questioners in the audiences online and in here in DC. So I'll wrap up the formal discussion here today, and again, thanks very much to everyone.